Torsades de Pointes is a specific form of polymorphic ventricular tachycardia occurring in the context of QT prolongation. It has a characteristic morphology in which the QRS complexes twist around the isoelectric line. Polymorphic ventricular tachycardia is a form of the ventricular tachycardia in which there are multiple ventricular foci with the resultant QRS complex varying in amplitude, axis, and duration. Most common cause of polymorphic ventricular tachycardia is myocardial ischemia or infarction. For Torsades de Pointes to be diagnosed, the patient must have evidence of both polymorphic ventricular tachycardia and the QT prolongation. Torsades de Pointes is often short-lived and self-terminating, however can be associated with hemodynamic instability and collapse. Torsades de Pointes may also degenerate into ventricular fibrillation. QT prolongation may occur secondary to multiple drug effects, electrolyte abnormalities, and medical conditions. These are combined to produce Torsades de Pointes. For example, hypokalemia may precipitate Torsades de Pointes in patient with congenital long QT syndrome. Recognition of TDP and the risk of TDP allows the initiation of specific management strategies. The risk factor for Torsades de Pointes are prolonged QT interval that's seen in the congenital long QT syndrome or acquired long QT interval prolongation that can be caused by various factors including certain medication, electrolyte imbalance, and the other medical conditions. Electrolyte abnormalities are hypokalemia, hypomagnesemia, hypocalcemia, use of medications like antiarrhythmics, antidepressant, antipsychotic, antibiotic, demographic factors like female and the elderly age group, cardiac conditions including myocardial infarction, heart failure, left ventricular failure, patient with severe bradycardia. It is important to note that the TDP is often associated with a combination of these risk factors. Individuals with several risk factors should be carefully monitored, especially when initiating a new medication that may affect the QT interval. Pathophysiology. A prolonged QT reflects prolonged myocardial repolarization due to ion channel malfunction. This prolonged repolarization period also gives rise to early after depolarization. RD after depolarization may manifest on the ECG as tall U waves. If these reach threshold amplitude, may manifest as premature ventricular contraction. Torsades de Pointes is initiated when a polymorphic ventricular contraction occurs during the preceding T wave, known as R on T wave phenomenon. The onset is often preceded by sequence of short-long short RR interval, so-called pause-dependent Torsades de Pointes, with longer pauses associated with faster run of TDP. Pause-dependent Torsades de Pointes is a specific form of polymorphic ventricular tachycardia characterized by a rapid, irregular heartbeat that occurs after a pause in the heart's electrical activity. It is often associated with prolonged QT interval, which can be congenital or acquired. During short rounds of TDP or single lead recording, the characteristic twisting morphology may not be apparent. TDP with heart rate more than 220 beats per minute are of longer duration and more likely to degenerate into ventricular fibrillation. Drug-induced QT prolongation and torsades. In context of acute poisoning with QT prolonging agent, the risk of Torsades de Pointes is better described by absolute QT interval rather than the corrected QT interval. The more precisely, the risk of Torsades de Pointes is determined by considering both the absolute QT interval and simultaneous heart rate on the same ECG tracing. These values are then plotted on the QT nomogram to determine where the patient at the risk of the Torsades de Pointes or not. The QT nomogram is a clinically relevant risk assessment tool that predict arrhythmogenic risk for drug-induced QT prolongation that can be used for risk stratification. A QT interval and heart rate pair that plot above the line indicates the patient is at risk of Torsades de Pointes. Treatment of Torsades de Pointes. Treatment focuses on both immediate management and addressing the underlying causes. Immediate management. Assessment of hemodynamic stability. The first step is to assess whether the patient is hemodynamically stable or not, like the normal blood pressure, good perfusion, electrical cardioversion or defibrillation. If the patient is unstable with a pulse, then synchronized cardioversion should be performed. If there is pulseless electrical activity or those with ventricular fibrillation, defibrillation is required. Intravenous magnesium sulfate. This is the first line pharmacological therapy for Torsades de Pointes. Magnesium helps to stabilize the cardiac membrane and thus it suppresses the electrical abnormalities that causes TDP. Typically administered dose of the magnesium is 2 gram IV over 1 to 2 minutes followed by an infusion if necessary. Magnesium toxicity should be monitored as high levels can cause confusion, respiratory depression, coma and cardiac arrest. Correction of electrolyte abnormalities, hypokalemia and hypomagnesemia are common causes of TDP and must be corrected. Discontinuation of QT prolonging medications. Any medications known to prolong the QT interval should be immediately stopped. Increasing heart rate. In case of bradycardia dependent TDP, treatment to increase the heart rate may be necessary to shorten the QT interval. This can be done by using temporary pacing to maintain a heart rate of 90 to 110 beats per minute. Otherwise, it can also be done by intravenous isoproterenol. It is used by continuous infusion to keep the heart rate above 90 beats per minute, especially if the pacing is unavailable. Long-term management, especially for congenital long QT syndrome. Beta blocker. First-line treatment to prevent future episodes of TDP by stabilizing the heart rhythm and blocking the sympathetic surge. Left cardiac sympathetic denervation. This is a surgical procedure. This may be considered in some cases, although its long-term effectiveness is less certain. ICD, implantable cardioverter defibrillator. This may be necessary for patients with high risk of recurrence and life-threatening arrhythmias. Gene-specific therapy. This is still under investigation for congenital long QT syndrome.